The title of this month's virtual growth forum is your hygiene department putting your practice at risk? And, I've been handing out flyers at speaking events that I've had the last couple months about tonight. And so we're really fortunate. We've got folks from all over the country that are here with us. And, you might think that's kind of weird, like a hygiene coaching company, a hygienist is implying that the hygiene department could be putting the practice at risk. And so, why did we, decide to tackle this tonight? Why are we positioning it this way? Because we want to get everybody's attention, right? We want everybody to recognize that our goal is always to create a triple win for the patient, the providers, and the practice. And by providers, I mean our dentists, our hygienists, yes, even our dental assistants and our business team as well. We want everything that we recommend and our clients are doing in their practice to be a win for all. And sometimes there are some things that are unintentional that create risk for the individual and also for the practice. And so tonight we'll share, some of those unintended business consequences of, maybe not having the opportunity to create as thorough of diagnostic records as is needed, the risk of undiagnosed and untreated periodontal disease, relying solely on clinical note templates, and then how does inconsistent clinical standards affect all of those parties, right? The practice, the clinical providers, and the patients as well. So let's just dig into this tonight. So these are just a few images of some of our amazing, fantastic clients. And as I mentioned before, they are really they're really, when they engage with Inspired Hygiene, they are really putting themselves out there for the opportunity to grow and learn and improve their clinical care for their patients, improve the communication within their team, and establish really clear clinical standards of care so that they have consistency between their entire team, and consistency within their hygiene department, especially when they have multiple hygienists, multiple doctors, super important. And so what I realized is that some of these risky practices don't just put the practice at risk, they actually put the hygienist at risk, they put the dentist at risk, and they put the patient at risk also. One of the things that I really love to do when I go to events, CE events and conferences, particularly large conferences like the Hinman or the ADA or the Yankee, is I look for CE programs that are mock malpractice trials. So I would encourage you the next time you go to one of these events to look that up and sit in on one of those. They are fascinating, and you're going to learn some things, particularly about documentation, record keeping, collecting proper diagnostics, and also just patient communication. But that's really what triggered this idea for me about tonight's growth forum. And that particular case was one that was really very tricky, and it was very complex about a patient that had been out of care, had come back in, had an active infection. They also had a joint replacement that got infected, and they tied that back to the dentist. So it was just pulling all of those details apart and really looking at that particular case. So I would encourage you, if you ever see that on the, the schedule of courses at an event, check it out. It's really interesting and you'll learn a lot. And what I recognize is in this particular case, the hygienist was initially named in the lawsuit. So I think back in the day, I've been a hygienist for a long time, and probably within the last, maybe in my first 10 to 20 years practicing, there was I'll call it a myth that the hygienists weren't responsible, that they would never be called, or responsible in a lawsuit. It was really everything, the buck always stopped with the dentist. But what we're finding is that that's not necessarily true any longer, that hygienists are being named in lawsuits, and hygienists should have coverage for malpractice themselves, because they do have responsibility for performing certain types of screenings, for documenting things, and just overall, providing safe, quality care that is up to the standards of care. So we're going to dig into that just a little bit as well. So here's our agenda for this evening. is we're going to talk about the prevalence and severity of cases that name hygienists in lawsuits. We'll give a couple of dental malpractice examples where hygienists were involved. And what are the most common areas of risk that we see at Inspired Hygiene in the hygiene department when we do chart audits? We're going to talk about creating consistent standards of care. And what are some things that you can do to start reducing your risk? So I have to thank Katie Panakian. She is an attorney with the Eastern Dentist Insurance Company. And I met her at the Yankee at the end of that course. She was one of the contributing attorneys to that program. And I went up and asked her a couple questions, and we started a dialogue. And through that dialogue, she really shared a lot of really interesting information with regards to what they see at this insurance company with hygienists when they are, named in these suits, and what are some things that dental practices as a whole really miss a lot of times, or maybe some things that they misunderstand. We'll say that. So I want to just thank Katie. She's with us tonight. She's not able to participate because of some personal commitments, but she's here. And I certainly had a lot of questions for her, and I appreciate um, her just contribution to tonight and her support of Inspired Hygiene. I would also say, as I was talking with Jennifer Stedman, our director of hygiene, she was very familiar with EDIC. She previously worked for a 17 location DSO, and EDIC was actually their malpractice insurance provider. And she said she had a really great experience with that company. They're not a sponsor tonight. There's not any type of partnership there, but I just want to give them a shout out of appreciation. And also, I would say that a lot of these resources that she provided are super valuable, and they are available to EDIC clients. So if you are a dentist and you are part of that network, if they're your malpractice provider, be sure you're reading their newsletters. And if you're a team member, ask your dentist, who's our malpractice provider? Again, I will reiterate, it is recommended that hygienists also have their own malpractice insurance. And, just make sure you have a good relationship with them, because they can be a wealth of knowledge for you when it comes to protecting your practice, protecting yourself, and just some of those nagging questions that you might have. You might not think to ask your malpractice insurance company, but I bet they would be a really great resource. I asked Katie, all right, talk to me about the prevalence of cases where hygienists are named in a lawsuit specifically. And what she shared was she went back through over the last 10 years over all of their cases and the number of times that a hygienist was specifically named in a case. And the good news is that the frequency of that is very low. It was around 1% of the cases that they saw. Um, the bad news is that out of those cases, the severity was very high. So these cases were involving undiagnosed periodontal disease, missed oral cancer, injury to the patient. Maybe it was swallowing a foreign body. Maybe it was a patient that was, injured somehow in the dental practice, even death in a particular case. And there were millions of dollars that were paid out as a result of these cases for settlement. So while the frequency may not be very often, it's certainly, these are severe cases, and it's something that you would absolutely want to avoid. And then the other thing that we looked at as we were putting this together was, okay, what about Inspired Hygiene's data? What are we seeing when we do chart audits with practices? And I'll say this is since 2021. So about 3 years, Inspired Hygiene has audited almost 1,400 charts. And this is part of our Hygiene Growth Roadmap service that we do. We do virtual chart audits, and we really evaluate what looks really great in the charts, where are the hygienists consistent, where are they really strong, and where areas that can be refined or improved. And here's what we find. And again, this is over almost 1,400 charts. 73% of those charts audited had a current medical history. And the way we define a current medical history is that the patient actually completed a written medical history and signed it within the last 2 years. So an update, right? An update is maybe the hygienist asks Tell me what changes you've had in your medical history. Are these the same medications? What surgeries have you had since we saw you last? And that's documented in the chart. But our recommendation is that at least every 2 years, a complete medical history is completed by the patient, where they have to say yes or no to all those different conditions, and they are signing and dating that. So that's really good. 73% of the charts had a current medical history. 51% of these charts audited, the radiographs were of diagnostic quality. I'm going to come back to each of these in just a moment. 37% had all pocket depths charted, and 44% had bleeding noted in the clinical notes, but it was not charted on the perio chart. 63% of the charts that we audited, based on the data that was there, radiographs, the clinical notes, the information that was in the periodontal chart, their medical history, 63% of them had obvious periodontal disease, and 59% of those charts had obvious periodontal disease but didn't have a treatment plan for periodontal therapy. So here you can see the huge gap in diagnostic information, and then also, missing or not diagnosing periodontal disease when it's present, and treating and preparing a treatment plan. Here's a couple things that we see. One is maybe the hygienist talked to the patient about the signs of periodontal disease, and the patient said, yeah, I don't think I want to do that right now. And so it was never put in the treatment plan. So maybe it was discussed. Maybe the doctor and the hygienist made a diagnosis together, but for whatever reason, they decided not to put that in the treatment plan. And when it's not in the treatment plan, then there's no documentation that that treatment was ever recommended, particularly if it's not in the clinical notes. The other thing that I will say, and we're going to talk about this in just a moment, is where it says all pocket depths charted. Well, we all know that pocket depth is not the only factor in determining active periodontal disease, right? But that is the minimum, right? The minimum that we're looking for at Inspired Hygiene to see, are they looking? Are they at least doing a perio evaluation? What are they recording? And the other thing is that it's very difficult for us to determine, looking at a virtual chart, maybe this patient had no recession, maybe they had no bleeding, and that's why those items weren't recorded. But what we know is likely there are a lot of those patients that did have other factors that would lead us to diagnose periodontal disease, but it wasn't recorded in the chart. The other thing that we see is bleeding noted in a clinical chart. It might say, generalized bleeding in the posterior, but it's never documented on that perio chart. And then what happens is the team recommends treatment. They treatment plan periodontal therapy. They perform that periodontal therapy. They bill that out. They send the insurance claim to the third party, and then they wonder why they're not getting a reimbursement, because they've submitted a perio chart that has pocket depths on it, but nothing else. And so it's possible for a patient to have pockets over 3 millimeters without bleeding, and that patient might be stable and healthy. So why would it warrant scale and root planning? So that's just an example of how not fully documenting the state of the patient can not only create risk for the practice, the patient, and the provider, but it also can create frustrations with those third-party payers. The other thing that you'll notice here is this 51% of diagnostic of radiographs, 51% of radiographs in these charts were of diagnostic quality. This creates a huge risk for the practice, because if there's ever a question about was this treatment necessary, but we can't see the bone level, then there's no way to prove that there was bone loss there. The other way that this creates risk for the practice is with an insurance audit. So if for some reason a practice was audited by the insurance company, and this happens, I would say more frequently with practices that are in network with an insurance company than those that are fee for service. But let's say there was a red flag somewhere and they decided to do a full practice audit. They will look at the radiographs, and let's say they've paid this practice, $30,000 in reimbursements for radiographs over the last year. And they do an evaluation, and 50% of the radiographs that they audit are not of diagnostic quality. Then they can require that practice to pay them back 51% of the reimbursement rate that was given to that practice over that period of time. So while that might not be a lawsuit, that's very costly, and that is absolutely a risk. Current medical history, just being very detailed with that is going to reduce risk because it's going to identify potential medical emergencies or things that could happen in the practice that the team needs to be prepared for. So I just wanted to share this data with you from a lot of charts. And here's the other thing to remember. Recently, I did a virtual chart audit with a practice that had no perio charts in any of the charts that we audited. And it was very clear that there was an immediate urgent need to really address the standards of care from the diagnostic standpoint. That's very unusual. That's not something that we run across that often. And what I will say about the practices that we do these hygiene growth roadmaps for, and those that we audit these charts for as part of that service, is these are the practices that are hiring a coach. And those of you that are in those practices that are hiring a coach, you may think of your practice as the average dental practice, but in reality, you're in the top 10 to 20% of dental practices. So this is the data that we're seeing in the top 10 to 20% of dental practices. Imagine the other 80% of dental practices, I would say is probably has lower statistics even in this area, I would imagine. I don't have data to prove that, but I think that's just a point to be aware of. Okay, so creating a standard of care is critical. That really is the first step in reducing the risk. And this is one of the first things that we do with our coaching clients when we're working with them, is help facilitate a collaborative conversation within the team of what are your practice standards of care. And so I would like to ask this question of, where do you think that where do the standards of care come from? And maybe if you have an idea, I'd love to see that in the chat. So where do our industry standards of care come from? What do you think? I'd love to hear what you all think about that. Do they come from previous educational experiences like dental school? Do they come from the ADA, regulatory bodies, like maybe that's the ADA, maybe that's the state board? Thank you, Lisa, for that. So I would love anybody else. Do you know where these clinical standards of care come from? Standard of care.
And feel
Yep.
free to unmute or anything too, if that's easier, depending
Yeah.
if you're on a phone or something like that. Inspired hygiene. I like that.
Thanks, Donna. Yeah. And Katie mentioned, Katie's our attorney guest. Standard of care is what a clinician would have done under the same or similar circumstances. So I understand that. And I guess from a clinician standpoint is, so who is that? Where is that bar set, right? Where's the bar set? And typically I would think that's determined by an expert witness, right? So maybe there's a dentist that's an expert witness that can testify to whether or not the service that was rendered or the treatment that was provided is similar to what another clinician would have done under the same or similar circumstances. But you guys get where I'm coming from with this. Like, where do we hang our hat on these standards? Where do we get these standards? So somebody said the ADA, the AAP, dental school and consultants. Thank you, Dr. Militu. That was actually on my list. Is what I would say is they typically come from CE courses, right? That you're being taught by somebody who is being positioned as an expert. The ADA absolutely has clinical standards that they share. And also, I'll share those with you. AAP, we base a lot of our standards on the AAP. And then dental school, and those standards might change over time. And then the Board of Dentistry. So I'm going to touch on a little bit of those different standards in just a minute and where some of those might come from. But yeah, you guys are right in line with what my train of thought is as well. But here's the thing. This is your practice, right? So you have the opportunity to take those standards, and I would say those are a minimum standards, and then create what do you want to have really clear in your practice. And I would encourage you to have this written. I would encourage this to be to do this over a series of meetings, perhaps, and do it as a collaborative body with your clinical team specifically, and then really educate your entire team on this so that everybody is aware of what your practice standards of care are. And I've talked about this before on some podcasts is, in my opinion, it's very important to have a practice standards of care instead of provider standards of care. Because if you have individual provider standards of care, that might mean each hygienist has a different level of care. And what you want to create is consistency and continuity of care within your practice. So dentists and office managers resist the temptation to just print this out because we're going to give you access to this and fill it out and say, okay, here are our standards of care. Your clinical team needs to be able to participate in this and have conversations about it, even question some of those standards so that they really feel like, okay, um, I some of this is going to stretch me out of my comfort zone a bit, but I understand where this is coming from, and I understand that the intent of these standards of care is to really make sure that there's that continuity and high level care for our patients, and so I'm on board. I'm agreeing with these standards of care. So use that in a very collaborative, um, a collaborative, I would say, method of creating the standard of care. So we're going to give you access to this this evening. Okay, so let's talk about a couple cases. These were examples. This was actually a case that I heard at another mock malpractice trial several years ago at the ADA conference. So a patient was seeing a general dentist for several years. Um, the general dentist and hygienist noticed an unusual area, an unusual lesion in their mouth, and referred the patient to the oral surgeon. The patient did not go to the oral surgeon and was out of care for about 2 years. Patient came back. The team referred the patient again to the oral surgeon. And at this point, the patient was diagnosed with oral cancer and it had metastasized to the point where within, a year or so, the patient died of oral cancer. The spouse sued the dentist for not informing the patient that there was oral cancer sooner. I will tell you that this was really interesting because the clinical notes from this particular case were not in a practice management system. They were on a paper chart. Okay, they were in a paper chart. They were minimal. They were not very detailed. But I will tell you the outcome of this case is that the dentist was found not guilty of negligence, and the reason is because the dentist actually had in the notes that they referred the patient to the oral surgeon multiple times and that they even followed up on the referral. And that was the key to that case. So it's not enough for us to refer the patient to the oral surgeon and then kind of just say, okay, that's all I need to do. It's their responsibility now, and just leave it alone. The follow up is super important. So making sure that we set a note to follow up with that patient, say, hey, did you go to the oral surgeon? What did you find out? Have you made that appointment? Have you been there? That was the key to finding that the dentist was not negligent in this particular case. Okay, so they had documented the referral, they had documented the follow-up, and that was the key. All right, here's another case. This was actually an injury during a hygiene visit, and the hygienist was named specifically in this case. The hygienist was taking radiographs, and the patient was hit in the head with X-ray machine arm, obviously by accident, right? Um, the patient said they were fine. They, dismissed the patient that day from their visit. Everything seemed to be okay. Obviously, the hygienist apologized profusely, I'm sure. And then a month later, the patient went to a doctor and the patient was diagnosed with a concussion. So, I'm sorry, they were concerned, not a month later, that's coming. So they were concerned. They went to an MD, diagnosed with a concussion shortly after they were hit in the head with the X-ray machine arm. Then a month later, they claimed to the dentist that number 14 was broken due to that same incident. And then they placed a lawsuit. So they made a claim. There was no way that the practice could um, defend themselves with regards to that number 14 because there was no x-ray of number 14 because the patient always refused the x-rays. So the point being was, in this case, was that X-ray refusal waivers are not valid. This is a huge topic, and we get questions about this all the time. And I'll just say I'm not an attorney. Katie might chime in if she's available in the chat. But here's, oh, she called the follow up on the referral a closed loop referral. So thank you for that term. I love that. All right, so the patient cannot refuse, the patient cannot sign off to be treated below the standard of care. And so this brought up a lot of questions for me with Katie as we were kind of chatting back and forth on this via email. And here's where dental professionals often go. They often go to the place of, okay, well, if the patient refuses x-rays and the refusal waiver is not valid, it's not going to be any type of valid defense, then I guess I need to immediately dismiss the patient, which creates a lot of angst, right, with the team and with the patient. Because, you know, not that you have a lot of patients that refuse x-rays, but you know, it happens frequently enough that we might not feel comfortable with dismissing all of those patients. So the questions that we went back and forth with ended up with this conclusion, which was, look, we all know that sometimes it takes multiple visits for a patient to build trust in their dental team. Particularly if they've been out of care for a while, or you know, they're new to town, they don't have maybe a direct referral to you, they've come from, you know, a new patient campaign or something like that, is sometimes it takes more than one visit to establish that trust, and sometimes it takes more than one visit for that patient to accept the treatment. So, and that's reasonable, right? Not every patient accepts your treatment plan when you're recommending a crown the first time you present it, but you don't necessarily dismiss that patient. Here's the key. The key is to not think that you can have the patient sign a refusal of periodontal treatment or refusal of x-rays and never bring it up again. So we need to be representing that treatment and just making sure that the patient is aware of the consequences of no treatment, the benefits of treatment, and that we are consistent across all of our team members and from visit to visit with regards to what we're recommending. So that was really interesting to me, to kind of hear her take on that from attorney standpoint, which to me is that's the deciding you know, voice in that. That's the expert on that. All right, so I'd love to do a quick poll if I could. I would love to know from you. Let's see.
I'm going to launch that, Rachel.
Yeah, I'm wondering if it's going to launch both of these questions at one time. Let's see.
I think
Okay,
it will.
yeah, let's go ahead and launch that.
Okay.
So I would love to know, first of all, what area of your hygiene department do you think has the biggest gap that you're most concerned about the risk to your practice? So let's just start with question number one. What area of your hygiene department do you see the biggest gap that concerns you the most with regards to risk to your practice? Undiagnosed periodontal disease. Keep those answers coming in. Jennifer, are you able to see the progress here? Yeah, okay, we'll share this in just a second. Thanks, everybody. Interesting. It's looking pretty even, honestly.
Yeah. 31% is undiagnosed periodontal disease. Oop, 35%. That just jumped up there. Yeah.
So a lot of areas to address. I want you to think about, over the course of the next few minutes, what is the one that you feel like you can address right away? What is one that you can address right away to kind of reduce that risk? Okay, so undiagnosed periodontal disease is taking the lead.
Mm-hmm.
All
Yeah.
right. So it looks like about a third of you have responded. So I'm going to go ahead and end the poll.
Is the
Thanks for
varsity
that.
practice over now?
All right. So you guys can see these results here. I think that's pretty interesting. And we're going to talk about these in just a moment, of the diagnostic radiographs as well, and oral cancer screenings. Okay. All right. So thank you for giving some feedback there. All right. So one of you or several of you said, well, our governing body or our state board. And so Katie had pointed me to this with regards to what's required to be in your records. And this is from North Carolina. And I will tell you, it took me a long time going through all of those rules and regulations to find this document, okay, or to find this piece of that document. And so this just really shows us what in North Carolina the dentist is required to maintain in the treatment records, right? Patient's name, their emergency contact, responsible party, a current health history. It doesn't say what the definition of current health history is. A diagnosis of the condition. So make a note of that. This is something that we also often see missing in clinical notes is a definitive diagnosis. And I will share with you as well is that's going to be required for reimbursement, right? That diagnosis. So if there's a crack in the tooth that you're recommending for a crown, make sure that that's in there. If you're recommending scaling root planing, make sure you have the diagnosis of active periodontal disease in there, okay? Specific treatment rendered and by whom. So details on the treatment that was rendered that day, the name and strength of any medications that were prescribed. Records may also include the following: treatment plans, radiographs, patient's financial records. But I was not able to find anywhere in the North Carolina state rules any standards of care. There was not anything that said how frequently a complete periodontal evaluation should be completed and recorded. There was not anything in there that said how frequently radiographs should be done, because that's all generally up to the judgment of the dentist, right? So I don't know that we can really depend on our state boards for standards of care. We might be able to rely on them for, what type of record keeping we need to have. And if you ever were called, before the board, or there was any type of lawsuit with regard to your documentation, this is what you'll be measured against, right? And if there's no mention of diagnosis of condition, then that's going to present a problem. And I would also say this is the absolute minimum amount of information that you should have in your clinical records. So, and this is North Carolina. So I would encourage you to go and look at your state and what you're seeing there as well. Okay. Okay. So ADA, yep, the ADA does have clinical practice guidelines and dental evidence. You can search this up on the ADA's website. There's about 10 different categories from use of fluoride to radiographs, but I will tell you, it's still not super clear. I did find on the AAP's website, I would say the AAP's website is sometimes a little tricky to navigate because there's so much there. But the good news is there's so much there. There's a lot of data there. This I actually found in the patient section. So this is basically patient-facing information on the AAP's website. And you'll see down here at the bottom, it says the AAP recommends an annual comprehensive periodontal evaluation. Okay, now that comprehensive periodontal evaluation isn't just pocket depth recordings, right? Remember, that is, all of the things that we're supposed to include: bleeding, pocket depth recordings, recession, mobility, furcation involvement, if there's any type of separation, right? And entering all that data that can also calculate clinical attachment level. So that's a comprehensive periodontal evaluation. So that is a standard of care that's pretty clear that should be happening at least annually on all of your adult patients. Okay, patient communication is really important. I think that a lot of these things can be resolved or at least risk reduced with certain types of patient communication. So when a patient refuses x-rays, for example, ask them why. Can you tell me a little bit more about that? Tell me more about your concerns. I want to learn about that and just understand where you're coming from. It could be a situation where the patient has just had some type of significant radiation treatment and they want to wait a little while before they have more, right? And that should be documented in your clinical notes. Um, it could be that the patient's had a bad experience with, periodontal therapy or what they think of as a deep cleaning in the past. And there might be something that we could explain or that we have not gotten to yet in our explanation that would help them overcome that. So ask those questions and really listen before we make a judgment of them being unreasonable. I know, I get it. I've been there too. It's frustrating when you have a plan and then all of a sudden, right, the plan gets curtailed because there's a resistance to take X-rays, and we need to have some conversations about that. Tell patients what you're doing. Our patients don't know how well we're taking care of them unless we tell them. Patients do not know when we're pulling out their tongue that we're doing an oral cancer screening unless we tell them. Okay. I remember meeting a dentist I think it was at the Alabama State meeting years ago, and he had shared with me that they had a patient of record and they had diagnosed periodontal disease. They had done non-surgical periodontal therapy on this patient. And for whatever reason, the patient moved on to another dentist, and that dentist diagnosed her with periodontal disease. Well, she reported the previous dentist to the board for not diagnosing the periodontal disease, yet she had consented to periodontal treatment of that disease. But for whatever reason, there was a communication breakdown, right? Maybe they didn't say the words periodontal disease. Maybe they said deep cleaning and she didn't realize that that was treatment for gum disease. So tell your patient what you're doing. It's not necessary to use very technical terms, but do your best to just make sure that they understand what the diagnosis is. Document that diagnosis, educate them on the benefits of treatment and also the consequences of no treatment. Okay. And then if they're not ready to accept treatment that day, then represent treatment when they come back, right? Don't say, well, they're never going to accept periodontal, treatment because they said no this time, and so we're going to just move along with the prophy, and we just kind of act like we never had that conversation. It's important to reevaluate their health. So if we need to do another periodontal evaluation, then that's appropriate to establish where are they today compared to where they were when we presented the treatment and made that initial diagnosis. So represent the treatment, document the patient's response to that, document that we communicated to the patient on the benefits of treatment and the consequences of no treatment. Follow up, right? If the patient says, I don't think I'm ready to move forward with that right now, ask their permission to follow up with them in a couple weeks to see if they have some remaining questions. Document that and then do the follow up. We have a document that we share with our clients that is a periodontal treatment diagnosis and treatment documentation sheet, essentially, where the hygienist fills it out. Once the doctor has confirmed the diagnosis, you have been diagnosed with blank, and it's stage 1, grade C periodontitis, and this is the treatment that's recommended. And they have to sign the sheet, and it has a little blurb at the end that talks about the benefits of treatment and the consequences of no treatment. And then you can have them sign that whether they accept treatment or not, and you have that as a document that they were aware of their diagnosis. And then there is going to be a time with a patient, if you have presented this treatment over and over and you're seeing their disease state progress, and based on their restriction of what you're able to do, you're not able to treat that disease. There does come a time where the doctor needs to have a need conversation with that patient, and it might be time to dismiss that patient at that point. It might be time to make a referral at that point if that's not already been done, to a periodontist or to a different dentist for second opinion or something like that. But there are times when that refusal becomes the norm with that patient instead of the exception, that it is time to have the doctor have a need conversation and decide whether or not this is a fit and whether or not he or she is comfortable continuing to manage their care. I'm going to see if we have any questions that you're seeing.
We do have a question. Yep.
Okay.
It says, "What is your take on telling the patient about perio gum therapy? I heard don't say deep cleaning."
Yeah, good question. We recommend not saying deep cleaning because the patients, a couple reasons. One is if a patient has insurance, a lot of times they think of their cleaning as the, I get two free cleanings. So it's very confusing to the patient if they say, well, I thought I got two free cleanings a year and now here's this deep cleaning and it's, $800. The other thing is it doesn't specifically connect the treatment with the disease. So if we're telling them that they have active periodontal infection, then we recommend telling them that we recommend periodontal therapy to treat that infection. So gum therapy, periodontal therapy, yeah, rather than a deep cleaning. Let's see. Katie says every screening performed should be in the chart. Um, Put it in the chart. So don't say in the clinical notes, I do perio screenings every visit, because that's actually really common, is that the hygienist they will use the periodontal probe, they will do some measurements and evaluate that. But if it's not in the chart, then it didn't happen. And if you don't have it documented, you have no defense. I remember another example of one of our clients that shared with me on one of our coaching calls that they had a patient that the doctor had done a filling on and given anesthesia. And the next day, after the procedure, the patient had a palsy in their face. Like, I'm going to say it was a Bell's palsy or something like that. But of course, they immediately thought that it was related to the dental treatment. Well, the practice went back and looked in their clinical notes, and guess what? There were no clinical notes about that procedure. There was no documentation about what type of anesthetic was given, how many carpules of anesthetic was given, where the anesthetic was given. And so, fortunately, it never went to a lawsuit, but if it had, they would have no defense because they had no documentation, they had no charting. Okay. At
Rachel,
what
we have
point do you
a question.
think, yeah,
Go.
at what point do you think it's time for that need a knee conversation? How long can someone hold off on treatment? I think that's a good question for Katie. So if Katie's available, maybe she can chime in on that one. Is there a reasonable amount of times that we have represented it if we have documented all of that? Is it, hey, we've seen this patient 3 times, we've presented the same treatment. What do we do? When is that time? And I think it's also up to the judgment of the dentist based on, right, how the patient is progressing. So negligent supervision could be a lawsuit when you're watching the patient deteriorate. So when you're seeing on the x-rays, bone level is continuing, furcation involvements are appearing, they're seeing more bleeding, the pocket depths are increasing, okay? How can a hygienist who cannot legally diagnose be sued? Oh, great question. Um, So I'm going to say this, and Katie can correct me, but even though a hygienist cannot legally diagnose, they are still responsible for certain types of screenings. So, and I would say if the hygienist, and Katie, please correct me on this, if the hygienist never collected the diagnostic information for the doctor to make the diagnosis, then there may be some association there. Um, but that's a very good question. So I'd love to get her opinion on that. Okay, another question. I have a patient that's very insurance driven. We've done 2 quads of scaling and root planning, and when she comes back, she'll want her free cleaning, and I'm dreading having her coming back and wanting to learn wording to help me with this struggle. So here's one thing I would say is we always teach, if you're enrolling a patient in their periodontal therapy, you enroll them in periodontal maintenance at the same time. So rather than wait until they come in to have that conversation, let them know up front, hey, so as we're moving into this, you have active disease, you've had bone loss. And so one thing that's important for you to be aware of is that in addition to this active therapy that we're recommending to treat the active disease, we're also going to recommend more frequent maintenance visits so that we can help you maintain the health that you're going to see, the results you're going to see with this therapy. And that's going to be a different type of procedure. And educate them on that, educate them on the frequency so that maybe you can give them a treatment plan so they know what to expect as far as their financial um, contribution over the next year, right? If they were used to having the 2 free cleanings and now we're recommending 4 periodontal maintenance, it's understandable if the patient comes back and all of a sudden we're changing the procedure on them. So we recommend giving them a heads up on that. Katie, the question was how can a hygienist um, how can a hygienist be sued if they cannot legally diagnose? So for undiagnosed periodontal disease, for example, or maybe missed oral cancer screening, something like that. So that's a good question. And while she's answering that one, there's another one that says, if a patient doesn't want radiographs due to other radiation, is that valid? You mentioned refusal is not valid. So here's the thing, having what Katie said was having them sign a piece of paper and thinking that that is going to absolve you from any responsibility, that's not valid. If the patient has a valid reason that they communicate to you and you document that reason, then we still need to, the next time they come in, if it's within reasonable standards of care for them to have radiographs, or if the radiographs are necessary for a diagnosis, then we have to mention it again. So we have to bring it up again. It can't just be like they sign a form and then we never bring it up again. And exactly, x-rays these days are so minimal, the benefit outweighs the risk, but patients don't know that. So it's important for us to communicate that to them. Okay, so Katie said if the hygienist has findings, the dentist won't put it in the chart, make a personal diary. So, um, okay, so for example, if the dentist, so let's say the hygienist sees signs of active periodontal disease and the dentist comes in and says, yeah, just clean their teeth today, then Katie, I believe this is the response, is Katie's response is make a personal diary. So have a personal, even if it's a notebook that you're keeping a note of that stays at the practice, of conversations you've had with patients, or you see signs of disease but the doctor did not diagnose it. But we still have a responsibility to do those screenings. And here's the thing, if you're in a practice where your doctor does not support you doing the appropriate screenings or doesn't support appropriate diagnosis, then does that fit with your clinical standards? So I think that's just a question that we need to ask ourselves. Hey Valeria, my friend Valeria says we have a few patients with advanced disease. They refuse to see the periodontist. So first question I would say is make sure you've made a written referral to the periodontist, and there's a copy of that referral, and that you have documentation in the notes that you've made the referral and you followed up on the referral and the patient didn't go. And then so we do what we can in our office, doing the perio in our office. What should we do? Continue to place a Band-Aid on it, dismiss the patient. We do mention the need for treatment every time, though. I think that if it's being treated in a prophy, which is, look, the reality is that there's no code to address that. There's no code to address that situation. So we do the best we can, but there comes a point where if you're seeing the patient continue to deteriorate, then it might be time for the doctor to have a conversation that this might not be the best place for them. Don't let the dentist throw you under the bus, is what Katie said, the attorney. Okay, had a patient come for scaling and root planing. Then doctor told the patient it's okay to bill out a prophy because you did. Oh Lord. Okay. Had a patient come in for scaling and root planing, and then the doctor gave the okay to bill out a prophy even though you've done scaling and root planing. So that could be insurance fraud. You're billing for a different procedure than what was actually done. Maybe you're talking about the subsequent appointment is to bill out for a prophy. I would bill out for what you did and then let the insurance company downgrade it. That would be my recommendation. Yeah, good questions. Okay, so let's move on. Jennifer, can you give me a time check? Can you just share that with me? Okay.
5 minutes.
Oh, okay. All right. So what do we do to start reducing our risk? And you guys, we're probably going to run over a little bit over 8 o'clock. So just hang with me, probably 8:15. What can you do to start reducing your risk? So have clear written standards of care that are followed by all. So it's not okay to have and I'm being really preachy to you guys tonight, but I think that's kind of what this topic requires. So forgive me for that, but it's not okay for three of the hygienists to follow the standards of care, but one doesn't. That's not okay. So clear written standards of care that are followed by all. Do regular chart audits and communicate. Let your team know. Say, hey guys, you know what? We're going to work on this together to get these clinical standards of care in place. It's going to take some time for us to get all of our documentation ducks in a row, for us to, get everybody caught up with a complete comprehensive perio screening charted every, year. Sometimes you've got to, for time management's sake, you've got to kind of um, triage that, right? Say, hey, we're going to do these three patients today, and then we're going to get these patients at the next time. Sometimes you can't get all of that accomplished at one time, and then just say we're going to do regular quarterly chart audits. And we have some clients who everybody on the team does chart audits. Some of them, the office manager does chart audits, but just let the team know that that's something that's going to be done. And it's not to be punitive. It's not to punish anybody. It's not to catch anybody, right? Because nobody's perfect. We're going to miss things from time to time. It's to protect everybody. It's to protect the providers, the patients, and the practice. So, and if you all have an understanding that there are going to be regular chart audits, then it's not a, pop up kind of odd surprise thing like, oh, I did a chart audit. It's something that everybody knows is happening, and you're expecting it. Clinical documentation is of utmost importance. So to what Katie shared was, you have to have it in the chart. If you're doing a periodontal evaluation, that bleeding needs to be charted in the periodontal chart. Oral cancer, I've got this document here. I think you'll be able to see this. This is an oral cancer standard operating procedure that we share with clients from time to time. In April is Oral Cancer Awareness Month, and we're going to be creating an oral cancer screening guide, and it's going to include a link to a new head and neck screening video that I think you guys will really like. And we're going to share with you our recommendations on, again, document the lesion thoroughly, follow up, follow up on that referral. So keep an eye out for that. We will be sharing that. The other thing I will say is, evaluate your x-rays. Are they of diagnostic quality? And I'll share with you in just a moment what I mean by that. Are you taking intral photos? These are great ways of diagnosing. Like with every patient, make sure you've got clinical photos of their whole dentition, or you have a scan. A scan is great. If that hygienist had a digital scan, they could see that number 14 was already broken, right? Before the patient claimed that tooth was broken. So a diagnostic scan, intral photos are incredible pieces of documentation. Make sure you have a diagnosis. When treatment is recommended, you have to have a diagnosis in the clinical chart, and make sure you have that current medical history that's completed and signed by the patient every 2 years. So those are some things you can do right away to start reducing your risk. All right, so evaluating your images. So I would love to know if a couple of you can put in the chat, what is this bite wing of diagnostic quality? Yes or no? Just type in yes or no. No, exactly. And I think you said both see what I see, right? We can't see any bone level on the mandibular. And these are the radiograph. This is a photo of this same patient, okay? So we know that there's some active disease of some level. And if we submit, so this is not an insurance course, but here's a pro tip is, if you did non-surgical periodontal therapy on the lower right here, and you submit this x-ray, it's almost always going to be an automatic denial. There's no documentation that they have bone loss. So when you're seeing those things, make sure you double check that and make sure your x-rays are of diagnostic quality and evaluate that. Okay, there was one thing I wanted to go back to here. Donna asked, should we have patients sign a consent for a prophy exam and x-rays every time? No, I believe that you can have a general consent form that patients sign when they become patients of your practice. That gives you they're consenting to being a patient, and what does that routine care look like? And I would say that the ADA has a lot of resources for patient consent forms, so that's one place to look. Also, perhaps the your medical malpractice insurance company might have some consent forms there, or at least they can review the consent forms that you create or that you find. So I would absolutely have them do that. But a general consent typically covers that. So if you haven't done that with new patients, you don't have that on file, that's something that you could update the next time you have patients update their medical history at the same time. So I'd love to know, what's one or two things that you feel like, hey, this is one thing that one area that I see that there could be some risk that we're gonna work on. Because you can't do it all at one time, right? Just don't attempt that, because then you get frustrated or overwhelmed, or your team's like, oh my gosh, you're coming at me. So what's the first one that you feel like you can work on? I'd love to see what some of you are going to address to help reduce your risk in the practice. What's one thing that you are going to begin to work on? It could be, all right, doing some chart audits. Okay. It could be printing out that standard of care. Yeah, putting diagnosis in the notes honestly is an easy one, because you already have your clinical notes. You probably even have a prompt there, or make sure you do have a prompt there for the diagnosis. So you're already doing that. It's just that one extra step of adding that could really make a big difference if anything ever came into question from an insurance standpoint, and also from a risk standpoint. Perio referral documentation. You do chart audits for your team, and it's been so helpful to see where we've done or where we've been slacking. Yeah, because we it's normal. You work in a very busy practice, I'm sure, and we get committed to something, and then maybe we get off track with it. So those chart audits help just remind us, like, hey, we've got to make sure that we're doing our oral cancer screenings and we're documenting that. Making sure bleeding on probing is in the chart. I love that. Yeah,
Great. I
lots
got
of
one here
hygienists to keep
too.
up with, for sure. Yes, Jennifer.
I got one here too. Working on x-rays to be more diagnostic and to make better notes. Those are awesome. Yeah.
I love that. Yeah, thank you. Sarah, thank you. Yeah, referring patients to periodontist as needed. And I would say one other piece in that standard of care, that standard of care worksheet is, when do we refer? So having a common standard within the practice, that's something that we see a lot with our clients, is they don't know from one team member to the next, like, okay, so when do we refer? When is that appropriate? Representing treatment that's been declined. Um, yeah, autofill notes are bad. Prompts are great. Yeah, okay. So this is from Katie, the attorney. Prompts are great, but just having notes that autofill in. I think what you're seeing, Katie, is probably what we see when we do chart audits, is the majority of the time, it's the same note on every patient. And that's going to be a screaming, if anything was ever called into question, that's going to be a screaming sign that we didn't document it, because every note is the same with every patient. Awesome. Thank you guys so much. We appreciate you, and can't wait to be with you again soon. See y'all out there, see you on social media, and hope to see you in person. Thank you so much.